So we shall go on to our last speaker, Dr. SHREYAS, who is a cataract, cornea, and refractive surgeon from the Eye Foundation group of hospitals. And he's also going to take a tough topic now, keratoprosthesis, should it or should it not be used for unilateral blindness? So on to you, SHREYAS.
Good evening, everyone, and thank you so much for having me over here. Type 1 keratoprosthesis for unilateral corneal blindness. I mean, to me, the statement itself sounds scandalous. And a few years back, I think I wouldn't have even thought twice about it. But in the last decade or so, our understanding of keratoprosthesis, the utility has changed, and a lot of publication has come in. And there is a certain perspective that we can bring into this topic today. Before I go on to bring in kind of a picture to this talk, I'll start with two case examples and then take it forward. So the first was a patient, a 70-year-old, who had undergone 3 grafts earlier and a fairly large graft. He was pseudophakic and presented with a failed graft, which was completely opaque and with scarring, so you would not be able to attempt endothelial keratoplasty. Other eye had 6/12 vision. The patient was keen on visual rehabilitation. So I did and undertook the patient for a penetrating keratoplasty and a large graft. And this was how the graft was. It was initially was doing very well, had excellent gain in visual acuity. And as you normally have in these large grafts, the astigmatism is so less and the patient was happy. But as you can see here, there was already a diffuse peripheral anterior synechiae, but the surface was healthy. And I knew sometime or the other, this graft is going to fail. And sure enough, this graft failed. And because of the large graft, he also developed very dense vascularization. And, the surface kept breaking down because of repeated bullae which formed. And again, there was a secondary graft infiltrate, which further worsened the amount of vascularization. At this point of time, I was hesitant to do another PK in this patient. And after a lot of counseling and discussion, went ahead with a pseudophakic keratoprosthesis. So this was after the type 1 KPRO and with a tarsorrhaphy, which I normally do in the early postoperative period in all keratoprosthesis patients. Sure enough, 1 year later, with the KPRO in situ, as well as the peripheral anterior synechiae, which are already present, the patient developed glaucomatous optic neuropathy, and he had to undergo a glaucoma drainage device. We did a Orolab aqueous drainage implant in this patient, and as you can see the tube here, this patient continued to do extremely well. And he's 6 years post-op now, and he's maintaining 6/9 vision. His fields are stable thanks to the glaucoma drainage implant. And most importantly, he's on regular 4-monthly follow-up and changes the BCL and maintains it very well. Second case, another patient who had undergone multiple grafts, now presented with early graft failure, but had high IOP and already had glaucomatous disc damage with diffuse PAS. Fellow eye was 6/9 with thin ERM. While I was not keen on doing a graft immediately for this patient, at least to save the eye for any future visual rehabilitation, we encourage the patient to undergo a drainage implant, as you can see the tube here. And sure enough, while the IOP did come under control, what happens commonly after any of these drainage implants, the graft failed and it was an opaque graft. And as you can see here, there was diffuse 360-degree peripheral anterior synechiae. So this was the second patient I had taken up at that time for a type 1 KPRO in the eye, even though the other eye was still a seeing eye. And 5 years post-op, this patient is on regular follow-up, does maintain stable vision with a stable surface. Both the patients already had a stable surface, no other risk factor other than the fact that they had a high-risk graft and, of course, glaucoma. So the question is, in these situations, we can either do a high-risk graft or a type 1 KPRO or do nothing at all. And these would be the 3 options that we have. And comparing type 1 KPRO versus repeat donor keratoplasty in this systematic review, we showed, and mind you, where they even included patients who had just undergone 1 graft earlier, not even patients with multiple grafts, with just even 1 graft earlier. But they found that there was a significantly better visual acuity gain, with 80% having better than 2200 versus 40% in the graft group. There was better retention and better clarity at 5 years post-op, with 75% retaining and having good vision at 5 years in the KPRO group versus only 47% in the repeat graft group. And the progression of glaucoma was similar. While we always talk about complications with KPRO and glaucoma being one of the most common ones, the progression between a high-risk graft and a KPRO is fairly similar. Now, looking into the literature itself for KPRO in unilateral corneal blindness, now these are two fairly large papers which have come out, one by Kosker et al. And another from Aldave's group, where they showed that it achieved similar visual acuity to that of the seeing eye with a KPRO. The follow-up in both these studies averaged between 48 to 60 months. And as you would expect, retroprosthetic membrane and glaucoma were among the most common complications. But while they were dealt with at different points of time during the follow-up, 82% at the end of the follow-up retained the keratoprosthesis in patients with multiple failed grafts. Now, looking at KPRO, where you compare it with patients who have undergone unilateral versus bilateral corneal blindness, and this was an important study which looked at a cohort where they had unilateral corneal blindness of KPRO in that eye and bilateral corneal blindness with KPRO in one eye. They found that there were similar visual outcomes in the eye with the KPRO which was implanted, and the complication rates and device retention rates were fairly similar. This is another important study which came out of Mass Eye and Ear, where they divided into two groups, where patient who had a bilateral blindness were in less than 2200 in the seeing eye and had undergone KPRO, and the other group which had good vision and had undergone KPRO in the contralateral eye. They found that while the initial visual outcome was similar, the complications were more in patients who had good vision in the fellow eye. And they also found that it was possibly because, at least they attributed it to the fact that possibly these patients were less cautious, dropped out of follow-ups, did not come regularly for follow-ups, and generally tended to present late when there was a drop in vision, which did not happen in patients who had poor vision already in the contralateral eye. Now, the points in favor of KPRO are that the other choice being, if you have to visually rehabilitate the patient, is a high-risk graft. We know the survival rate is poor. And with these highly vascularized grafts, it's almost like a solid organ transplant. And if you want the graft to survive, you have to put them on systemic immunosuppression. But with a patient with a good fellow seeing eye, the risks of systemic immunosuppression outweigh the benefits. And again, with the KPRO, with better techniques now, better material with titanium backplate, which reduces the rate of retroprosthetic membranes, and our better knowledge on how to handle complications, the follow-up required, the bandage contact lenses, etc., has definitely lowered the frequency of complications in well-chosen cases. There's also been a couple of studies which have looked at the quality of life and the binocular visual function in patients who have undergone Boston type 1 KPRO with the other eye, which is seeing. And they found that it does restore binocular vision to some extent. The patients have a better visual field, improved motor skills, and patient safety and quality of life. And importantly, it had lower anisometropia in comparison to a normally than where the other eye has undergone a graft. Obviously, the incidence of high astigmatism is certainly lower in a patient with a keratoprosthesis. So this also gave useful binocular vision to the patient without glasses or contact lenses. So the points against KPRO, and I cannot emphasize this enough, points against KPRO in unilateral corneal blindness is that the primary indication of KPRO when it started was for bilateral corneal blindness, and this is not without reason, because there is a significant risk of losing that eye altogether with a keratoprosthesis. Whether it is because of retroprosthetic membrane leads to subsequent recurrent melts, glaucoma, which has not been treated adequately with a glaucoma drainage device, a repeated incidence of vitritis, which is common in KPRO patients, and of course, a higher incidence of retinal detachment. So there is a greater risk of losing the eye altogether. But again, papers have shown that while KPRO is being done in extreme eyes, where it is a last-ditch effort to bring back vision, it is important that we prognosticate based on the primary condition. Wherever it has been done, where there are not multiple risk factors, like in a failed graft, or even in some cases of aniridia, the long-term outcomes and retention rates have been much better than in patients with a high-risk graft, limbal stem cell deficiency, poor blink rate, neurotrophy, all the other risk factors which actually can further increase the risks which are there with the type 1 keratoprosthesis. So to conclude, careful case selection is extremely important. Pre-op counseling, explaining the patient for lifelong meticulous follow-up, the risks that they are going to entail by undergoing a KPRO, the risk of even losing vision completely in that eye or losing that eye itself. Although if on regular follow-up, even if there is a melt, we can do tectonic PKs and save that eye again for a potential repeat KPRO or even replace the device with another KPRO. But all of this can be done only if the patient is on meticulous KPRO. And of course, understanding the underlying causative factors, handling post-op complications, especially glaucoma with adequate drainage devices in a timely manner is extremely important whenever we are considering this in such a situation. Thank you so much for your kind attention. I look forward to the views of the esteemed panelists.
Thanks, Shreyash. That was a difficult talk and very well managed. And I look forward to hearing from Namrata, Merle, Radhika, Dr. Amma. Any questions?
I think Dr. Radhika will comment first.
I would like to compliment Shreyas because he has nicely covered all the angles and has highlighted absolutely all the required points. It's also important to gauge how much the patient and the family is understood, because we say but sometimes they don't absorb or internalize their implications. So that's important. And yes, I do agree that it's not the way when KPRO first started, it was absolutely like an end stage procedure as a last option. And for bilaterally blind, there are certain patients who are really keen on having vision in that eye. They've had multiple graft failures, and as long as they understand that it's all the complications which you mentioned, it's not something that you definitely will say no, it cannot be done, etc. There is one thing to explain also about the cost, because it requires kind of about an additional 1,000 to 1,500 rupees every month. And the follow-up is absolutely important. So that's something which needs to be emphasized. And the quality of knowledge has improved so much. The devices have improved so much. So it's definitely an option which has to be kept in mind, which can be offered. And you can have patients, as you showed, with 6 to 7 to 8 years of good vision. And generally, I find that people who have somebody who can care for them, I mean, it's the people who are non-eyed, who are absolutely alone, have no help with the eye drops, no help reaching in time. They're the ones who really need it, and then the ones who actually suffer from the procedure. But the ones who have a caring family, or they have ability of somebody to take care of them, bring them quickly, they literally have to report within 24 to 48 hours of developing a problem. And so careful case selection and your own commitment to the follow-up, that's very, very much an important aspect.
Does it make sense to have a glaucoma drainage device put at the same time as KPRO, or one very complicated surgery and combining it with another makes no sense?
No, it's not necessary that it makes no sense. Definitely, if the patient has had multiple grafts, has uncontrolled glaucoma, and if tube shunt is required, you can do it in the same sitting. You can do it as a staged procedure also, depending upon the case. But if necessary, you can do it in one sitting, because that way the surgery is very forgiving. The type 1 Boston KPRO, it doesn't matter, what is the status of, because the cornea, the host cornea, or the rest of the cornea, if it becomes very hazy, doesn't matter, because it's the central optic which is going to give you the clear vision. The problem with if you are putting a glaucoma drainage device, and one should put a valved device, because without a valve there is a risk of endophthalmitis that increases. And so yeah, you need to have a whole team. Either you do it yourself, that you put the glaucoma drainage tube yourself, or you have a glaucoma team, and then you as well, the corneal team, and sometimes retina team as well.
Yeah. Yes. Yeah. Any other questions before we conclude?
If I may add just one point on that.
Yeah.
Also, I mean, the timing of the glaucoma drainage device is also important, especially as Madam mentioned, if we are using a non-valve device, it is going to take 6 to 8 weeks for IOP to come down. And this is a window of time when, we can potentially lose the eye to glaucoma because of high IOP. And there have been times where even an orphan trab has been done. We know that the trab is going to fail, but it's just that the trab works for that 4 to 6 weeks till this takes place. This is especially for patients from our part of the world who can't afford a little more expensive Ahmed valve, and the RD is definitely at 1/10 the cost, and we are able to offer it at a much lower price.
Yeah. Yes, very well covered. So I think it goes without saying, I'm sure all of you would agree with me that it's been an amazing webinar, and there has been so much of learning in every topic, so beautifully dealt. And I think truly kudos to the speakers and the expert panel for ensuring that all the right answers were given. And we actually end this webinar with a whole lot of information. It's just that you wish your gray matter holds on to all this information instead of letting some of it go off with a period of time. So thanks a lot, expert panel. Thanks a lot, dear speakers. It was just wonderful. And I'm truly thankful to Dr. Rajesh Fogla, who actually stepped in because Dr. Rishi couldn't join, and he really manned the earlier part of the webinar so beautifully well along. And my thanks are due to the Mr. Kripal and the AIOS admin team for their being constantly supportive and encouraging for all these webinars. And I think actually I should thank Dr. Namrata Sharma primarily for being so very supportive to ensure that IARC webinars do happen in the regularity in which it is happening. My thanks are due to Sai and Manjula from Numerotech for all the mails they keep shooting to your inboxes, which I'm sure keeps you all updated to see it on the day of the webinar or probably later too, because I'm sure ARC website is very actively being used. And our thanks are very much due to Mr. Anand and his entire team for how meticulously they time it and how gently they remind us. And it's an amazing group which has helped us run these webinars well. Our thanks are so very much due to Entoad, because they have been our constant sponsors and such a source of encouragement that we are able to reach out to all the attendees in a timely manner. And thanks a lot, dear attendees, for being there as a constant encouraging factor for us to keep coming back to you all with more webinars. Thank you, one and all of you.
We want to thank you, Chitra, for doing these excellent webinars week after week, tirelessly, and with such enthusiasm, and collecting all the best speakers in the country on the same platform. So,
Yes, I would also like
kudos to you. Yeah, kudos
I
to
would
you.
like to appreciate your comments, and your way you handled the discussions and all was really very, very nice.
Thank you.
Thank you so much. Yeah, thank you so much.
Thank you, everybody.
Thank
Bye-bye.
you.
Have a
Bye.
great weekend.
Chitra's program gets made 6 months before, actually. She's so
Wow.
organized.